Good morning, everyone. This is Pat Scow. I'm the Executive Director of the Illinois Critical Access Hospital Network. And as you know, ICANN has partnered with ADCO, and ADCO is a technical development company, and we have created Survey Solutions by ICANN. And we provide HCAPs, CAPs, a variety of tablet surveys. I think we have close to 20 different types of survey, whether it's by tablet or email, or the HCAPs, the traditional mailing, but it's a program that we've had in place since 2012. And very excited about having you all join us today. And it was one thing that we wanted to make sure that as we grow our organization and our program, that we provide ongoing education and value for your participation in the Survey Solutions program. So like I said, I'm very excited to speak to you today. And my topic I'm going to cover is about patient satisfaction rounding. You might ask about my experience. As you know, I'm the Executive Director of ICANN. However, past lives, I'm a nurse. I've been bedside nurse. I've been a nurse aide. I've been an educator. I've been assistant administrator. I've been director of nursing. As you know, recently I rolled out the critical access program and worked with many hospitals. Been involved, as now the executive director of ICANN. We have 57 members, and I'm the immediate past president of the National Health Association. So I've been involved with patient care for a long time, also in running an accountable care organization. So my experience is going to come from what I've learned in practice and from others and what's relevant today. So stay tuned here. So we'll get started right now. So today I want to cover, background about the patient rounding. And the reason we're talking about patient rounding is it's become something that's very important in our skill sets of what we need to provide in the hospital and other settings. It's a way of connecting in. We're going to talk about different types of rounding, kind of the steps and some tools that implement and how to evaluate your program. So let's get started, because we all want an A, we all want to be top notch. We want to be in that upper percentile. And so as in your capacity and using HCAPs and other kind of survey tools, you want to use, you want to look at and evaluate new ideas of how to improve. And hopefully, what I'm going to talk about today is common sense, probably nothing new that you all don't know, but it's maybe pulling together, giving you an idea or giving you that jump start to look at this as an idea. So let's talk about patient rounding. And it's really the practice of checking patients on a routine basis or individuals in a waiting room or whatever. It is really not a new process. And historic is the first thing out of report for nurses. As a young nurse, that was the first thing I did was, as soon as I heard report, grab my notes and I go around and see all my patients and kind of set up in my mind when I'd come back and check on them. Maybe it was during medication, maybe it was when I did vital signs, but we've done rounding over the years. You also remember, physician rounding and things like that. Rounding from nurse to nurse and caregiver can vary and be inconsistent, and why we've moved to a little bit more sophisticated or a little bit more quantified rounding rather than what we did, naturally, or we learned to do, in practice, either if you're a housekeeper or a nurse or a physician, whatever. And it was really Quint Studer who really quantified it and made it really a key process for hospitals and other organizations to be successful, is really dealing with the rounding. How do you keep that ongoing communication for quality improvement patient experience? And I really think he put it on the map. Stuff that we'd done indirectly or we planned to do it, or stuff that we've done historically, but he really made it make sense. And so I really attribute that. Since then, the Institute for Healthcare Improvement, IHI, has endorsed hourly rounding as a way to recall flights and falls and things like that, improve quality care. They're looking at that. And the Agency for Healthcare Research and Quality acknowledged that these rounds are the best interest of the patient. And we know the poor communication is often the root of many problems. So, it's really elevated its concern and interest, and why we have to be good at it, and how that then in turn impacts, our satisfaction score. So really, what does rounding mean? And this is just my own coined perception, is periodic and purposeful checking on patients, visitor areas of concerns. And it has to be really scheduled and priority. As I said, it was a priority when I got out of the report and went and saw my patients. It was kind of a scheduled thing. And I did it indirectly, but I didn't make it as purposeful as we're doing it today, and to improve it in standards of care. But there are a variety of rounding, and the most common is nursing. And what we're going to probably talk about more today is the inpatient rounding. Physician rounding, gosh, I remember as a young nurse when physicians made the round, we gathered up the charts, put them in a basket, and away we went and followed the doctors around. And they usually did that in the morning, and they did that in the evening. And then we have administrative rounds. I think that's something that's happened over the last maybe 10, 15 years. Administrators have gotten out and they do their rounds, whether it's the CEO or the director of your department, whether it's lab or nursing, whatever. And there's other types of rounding, multidisciplinary, where groups go together. Teaching, we've all been in medical, in the clinical setting where you have medical schools or nursing schools, they do kind of rounding. You can do safety rounding, maybe that's done once a week with the safety committee, or infection control. We've done particularly with COVID. Public relations, you might have a patient advocate that goes around and does rounding once a day. In housekeeping, I think that's something. Nursing and housekeeping are probably ones that do it most often. Now, Studer really added a special name for rounding programs, and you're probably very familiar with this, but I just want to set it as a basis because I think it's really important, and it's helped to frame that process for much better than my rounding I did as a nurse or an administrator. But it's ADIT, acknowledge, introduce, duration, explanation, and thank you. And that's kind of the key thing. So it's really that communication platform. And I credit Richard Rubin with Sturban, who coined that evidence-based communication framework. And so what does that mean, so to speak, with the acknowledge, it's the communication. Hey, I'm your nurse today, and, I'm here to take care of you. I'm going to be with you for a period of time. You're to explain what's going to happen, and you're obviously going to think and what you can do. But during that discussion, your framework of your communication, goes often and looks at key areas of ADIT that we talk about, and that's pain, when you're finding, you're trying to, find out how the patient is doing. Do they need to use the restroom, potty, whatever, position? And are they comfortable? Those are kind of the 3 Ps that people have to do. And comfort is key in that when you're doing that, explaining yourself, what can I do to make you more comfortable? You're looking at the environment. Anything I can do for you? When you're going to be back, and thank them, and then kind of logging that in. And so we're going to break those really steps down as we move along. So who really does patient rounding? And I alluded to that earlier, but anybody involved in patient care or support services really does kind of a day-to-day type of rounding. It's nurses, housekeeping, you often see dietary people, patient advocates. We talked to the types of rounding that people do, but it's really that scheduled, purposeful and priority type of rounding. And it's done in a variety of settings, and we're seeing it even done in the clinic setting. So, and really, why do we do it? Because it's a way of putting our best foot forward, allows you to address problems and concerns right away. Patient rounding is always the observation, taking care of the patient, but also really that communication, finding out what's wrong, being ahead of things, and making the person feel comfortable, which in turn, as we talk about, impacts their perception of the stay. So rounding practice, schedule times, like I said, this is all common sense and stuff that you probably do. I'm just going to quantify it and really give you some ways to think about it differently. The scheduled times in the inpatient setting is usually an hourly by the patient care team. Obviously the nurse that's providing care, she probably can't do it every hour because she may be doing treatments, admission, but then there's somebody part of the team, maybe it's the nurse aide or the tech, or they know that the physician will be making round, or the nursing student, or whatever. There needs to be something set up if you're going to do it as in an inpatient setting, and that's generally how it works. And you try to combine it with tasks and other things that you. When it's administrative round, it's usually daily. Often it's done when it's not bath time or eating time or things like that. You try to do it when it's easy for the patient and or family in the room to talk with you. Physician rounds rounds, they can vary. It used to be, gosh, they would get there at 6 or 6:30, 7 o'clock, because they get that lab work on the chart, or they're before surgery. You kind of know when your physician or practitioner will be in to make rounds. And sometimes it's twice a day, and so you have to be prepared for that. I don't think you have to gather up. I'm going to date myself when I say this. When I was a young nurse, when the physician came on the floor, whether it's a male or female, and you were going to go with them on rounds, you stood up, and like I said, we had a little basket, a cart basket. We put everything in. We went around, and that's really different. We have computers and other ways of doing it now. In emergency department outpatient areas, that's generally not, it can be done every hour, but it just depends on the procedure and your workload. Particularly it's important these days in emergency department when you've had trauma that you periodically say, I need to go out and meet with them every 15 minutes. Sometimes they're really built for the situation, or you have a big outpatient schedule of endoscopy procedures or outpatient surgeries. You're going to want to round on them, on probably an hourly basis for that 6-hour period of time. And remember, it's always about the patient or the family, and it has to be purposeful. And you're going to hear that over and over again. And so you're saying, okay, Pat, why initiate a rounding program? Why do we want to go through all that trouble? And there, like I said, there's a lot of ways to do that, and we'll talk about that. But it's a way of helping you focus on what matters. I really think that it's a great way if you're particularly wanting to improve your HCAP scores, and because that really deals with inpatients. It's really a way to look at ultimately improving care, because it's that constant observation, that communication. It's about quality improvement. Maybe you have things like in an outpatient surgery area. If you're making rounding there, you can check to see if the patient's warm and getting them a warming blanket. Those are quality improvement on the comfort, patient experience, and that's the goal of the organization. We want people to have a positive experience. And maybe your hospital's had a poor rap. I mean, that happens easy, especially with social media. You go on Facebook, boy, the nurses didn't come and answer my light and all this stuff. And so, it's a way of being a step ahead. And maybe you're trying to improve the performance in your unit or your radiology department or lab department, or not lab, not necessarily, but in some of these areas that you want to involve them and make sure that we make these improvements in staff's ability not only to relate with patients, but their ability to follow up. And sometimes you do it as public relations, that's an administrative thing. And there could be other reasons that I'm not even mentioning today, but you have to understand why you're doing it, why it's going to matter to you, because that really drives what you're going to do. Now, you're all in our HCAPS program, and, now it was 33 questions. Now it's down to 29. And these are the different categories. And, through Survey Solutions, you can add up to 5 questions, prepared questions that we have, but these focus on key areas that we know are important. And I didn't cover CAPS, outpatient area, but really going to talk about inpatient primarily today. But it's communication with physicians, and I add practitioners, because in many of your places you have nurse practitioners or clinical nurse specs taking care of your patients, and it's really that communication with them. And are they informative, and do they tell you the plan of care? Communication with nurses, are they being helpful? Are they being compassionate and responsive up to the staff? Are they getting you up to the bathroom, and all these things? Pain management, on a scale 1 to 10, are they timely with it? Communication about the medication. I think this is key, particularly, patient being discharged, and people want to know what they're taking. And, we want them engaged in the care, and how well are we doing? And this is what it measures. Cleanliness of your hospital. That's something first we see. Quietness at night. I remember working 11 to 7 and, having to be very careful of noise and things like that. And nurses talking at the desk, or plant people walking back and forth and making rounds and talking as they do that. And discharge experience, willingness to recommend food over a hospital rating is all kind of packaged together. And so, rounding really helps you to focus in on those key things. So patient expectations, and, bottom line, people come to your hospital or to your clinic or to your outpatient area, they expect you to be competent. that's really a non-issue. If you're not, then I guess we're in the wrong business. But what really is being measured, particularly on inpatient satisfaction, some a little bit your skills. I mean, they expect you to be competent, but sometimes, how skillful are you? That is somewhat measured. But it's nice. How responsive are you? And so, you don't. So that's really what we're looking at, is how do we get the patient's perception and their family members of the highest quality of care. Why the best care fails. You could be the most technically competent people. And haven't you seen that? You got the best nurse or the best doc, and they're just so good at what they do, but yet they fail. Patients are disgruntled and things like that. And it just boils down to their communication skills. And haven't you had somebody in the past that, maybe not as maybe they're at a B- level or whatever, and yet their patient or their family think that they're at an A+ level because they're so good at communicating. So what we really want to do is achieve an A in both. And service quality, lack of kindness, nicety, sincerity is really what we're getting at. And rounding can catch staff attitude and change perception, not only in satisfaction scores, but the coffee shop. So, you want that genuine expression of caring and being proactive. So let's talk about survey findings and proactive and reactive and focusing on scores. What do you want to improve? Are there problems such as complaints about pain management? Is the room is dirty or cluttered? And you want to be reactive and need to improve. So when you say, okay, our scores are this, and if we initiate rounding, what are we going to want to improve? What are we going to focus on? And that really helps with your scripting and building out what you want to do. So when you're making your rounding, you don't have to follow the Studer plan, but it's got to be relevant to you. If you really focused on, you've got poor scores for food quality or why the hospital won't, the patient won't recommend your hospital as always, and maybe sometimes, or on a scale 1 to 10, maybe at a 3, well, you need to find out. And rounding and changing how you take care of patients is that first step. If you got great scores, it's a way of keeping those great scores, being proactive and keeping that high bar. And remember, one of the reasons you want to consider rounding is even though you're getting these survey results, they're often 3 to 4 months old. So when you do rounding and you're a little bit more proactive, and that's one of the reasons why hospitals have built it and made that a concentrated and scheduled process, is because they want that ongoing feedback. That's very, very important. And, if you want to stop and ask me any questions or share a situation, please feel free to jump into chat. And I'd love it if we were sitting around the table or whatever, then we could really talk about our situations, because we've all had those bad experiences. We've all had those wonderful experiences. And we can all talk about when rounding would have been valuable, or when it, how we could improve upon it. So feel free to be comfortable about that, and stop me anytime. So anyway, the real value, as I said by the previous slide, is that it's a tool for feedback now. And whether you're doing it in observation, or sometimes people are using tablets now that the patients can do every day, a variety of way of getting that ongoing feedback and rounding, and a way that we can use it in measuring it. Patient team, it's a way that, as the team, if quietness at night is a problem, it's a way that the team can come together. But if you're going to make the improvements, you got to start with the team. If it's quietness at night that you're focusing on, you want to sit around with your team and say, okay, we want to build consistency. We want to be responsive. We want to be alert to patient changes. So how do we use rounding to fix that? And how do we take our score from a 78 to a 95? And focus on that quietness at night. So, you can't, the nursing director or the director of the unit can't say, okay, we're going to start rounding tomorrow. It's got to involve, understanding what the team sees about it and how we can build that into the day. I mean, you can't just start it without everybody being involved. And it, like I said, it's a wonderful tool. Administrative, if they're going to do it, they really got to understand why they do it. Because if you go out there and you do that and you're really not picking up on things, it's kind of wasting time, but it can be such a valuable tool. It's kind of goodwill. It builds a culture of that you're caring about the patient, you're caring about your staff, and so forth. And like I said, I wish we were sitting around the table and we could talk about the examples where, rounding, administrative rounding really made a difference. And other times you're like, oh, I don't know. So, but anyway, when you're doing it, patient care has to come first. And I'm just mentioning a few things that, when you're talking about patient care, what we want to do is talk, about how do we look at management of pain, helpfulness, about care and treatment, medical plan, and that handoff. That is so important that, we have to, and we'll talk about that, and the outcomes, discharge needs. So when you're thinking about rounding, in your checklist or in your process, as using the AIDET, thinking about the different categories in your satisfaction surveys of helpfulness and treatment and things that you think you would do automatically, but we get busy and we forget. So that's why, making it a priority and purposeful really makes a difference. So let's talk about some of the tools for patient care and how we can use that. So hospital culture, you really need to evaluate before you start adding rounding. Nothing worse is okay, tomorrow we're going to start rounding. Okay, nurse B, you've got to do this. Ward clerk, you got to do this. Housekeepers, you got to do it 3 times in a shift. And, I want you to report this. But yet when people have done rounding in the past, maybe somebody has chided them for taking action with a patient. And so they, if you all of a sudden throw it on them and they've had a history of not being supportive when they made changes, that's not the right culture. So you've got to make sure that the readiness is there. Are you really ready to do that? And do you have communication processes in place? So if you're going to start rounding, how do you follow up? And how do you record this? And how do you begin to do this? And are you open to solve problems? As I said, you don't want to have staff that are limited in what they can do. Granted, sometimes they can't go out and spend time looking for transportation to help get you home, but they should know who to call within the organization to help that person, if they don't have a ride home. I mean, and they've got to be willing to go ahead and take that next step. And I love when I walk into hospital. I'm in hospitals all the time, except the last for, with COVID here. But, when people come up to me when I'm in the hospital visiting and on my way to administration or some particular place, that they say, oh, can I help you? Or, I've had an issue. They're willing to solve that problem. So, you have to think about culture and have it ready. And so, and if you decided to do it within your unit, you really need to have your director of that service or nursing or COO or hospital CEO, be in full support. And I think you need to talk with your medical staff, because you're often going to be, maybe catching things and following up more frequently, and they have to be prepared for it. So, rounding has really quantified to, some particular areas in a framework. And Studer has really done the best job. And I looked around again to see, in the literature, is there anything else that I've missed? And they really have the best framework, and I really like it. And so the in the bold are actually out of the Studer book, but in the italics are really my interpretation. So when you're doing rounding, it's really setting expectations. And when you come in and you greet and you inform the patient, okay, this is what we're going to do today, you're evaluating, you're letting the team know that you're going to be rounding and why you're doing it. You're going to come in every hour. It might not be me, but it might be my assistant. You're sharing information, managing up. You're sharing information about the team, the experience. Like if I'm doing the first rounding, if I'm the nurse, I'm going to say, hey, your nurse tech is just outstanding. She's been with us for 6 years and he or she, does a great job. Or, you're going to have a CAT scan in the next hour, and you go down to the radiology department, and, those techs, they've been doing it for years, and we have great results, and they'll be very informative. So it's kind of, making sure the next situation is going to be a positive experience. Harvesting, a lot different than I used to just sign off, send them on down. It really helps with that communication. The patient is saying, oh, okay, I can do this. harvest the reward and recognition. You know, that's one of the things you can say, hey, we were able to fix that yesterday, Mr. Smith, by, changing the, getting you to the bathroom every 2 hours instead of just when you use the call light. Did that make a difference? And thank you for helping us make that work. And, closing statement, when you're going to be back or who's going to be back, when the next treatment, and then anything you've picked up, sharing it with the team. And if there's problems, to say, oh, I didn't get my pain medication. The nurse on the last shift didn't give it to me. It's the follow-up, and how do you do that and take care of them? And I say, oh, that, gosh, I can't believe they forgot again. It's easy to say that stuff, but all those things are heard by the patient. But, thinking about it and being purposeful with it, has much better outcome. And obviously training is important. And Studer, picking on Studer again, but they're hardwiring. And so strategy is still the best practices. And it takes time and ease communication for staff. And it provides consistency. And a lot of people use scripting, and it's ongoing. You can look at the picture, when you're doing training, you're going to have all sorts of personalities in there. Some are being like the first gal in there, first person in there. She looks really receptive and say, hey, I'm into this. The other guy's got his arms crossed. I'm not into this. So when you're doing that hardwiring, or you're beginning the process and you're wanting to engage the staff, you have to think about how they're receiving it so they can be engaged in it. So you're hardwiring. My son just recently has decided to go into nursing and has been in the business profession. And so he's working at the health tech, and they've helped him with scripting. And he's a very good communicator, but he didn't know the lingo. And this is something that we didn't do very well in years past. It's really helping that new person and scripting them better. We just kind of, oh yeah, this is all going to work out. So I really like the idea of helping with scripting. After you've done it for several times, you start to put your own twist on it, or you add, your inflections are differently, and that's neat to you, and that's unique to you, and that's okay. But you want to have that basic framework. And I think it's good when you start out. And that's really why the scripting. Now, some people can say, I don't like scripting because, sounds canned and so forth like that. And that's what you want to avoid. But the most positive is, like I said, it provides that consistency, and the questions are the same. So the patients really kind of know that you're really planning together. So if you say, how are we going to manage your pain today? Can you get on the scale 1 to 10? Or maybe you have a whiteboard and you have it, scale 1 to 10 up there, or 1 to 6, whatever you're using, and circle it. And it really helps improve the handoffs if you've got the conversation there and the perception. And we've all had those grouchy staff. So if you're having a bad day, or you have days when days go wrong, and so if you have that kind of hardwired in there, you're much more comfortable in that relationship. And not everybody's a good communicator. We all don't come, versed in being a politician and being able to say anything on the spontaneity there. But so, helping with scripting helps you to be a better communicator. But lastly, you have to be sincere and genuine. The value of listening. And gosh, I think I have to tell myself many times, slow down, think, listen, because that's really critical. And it's even harder for you all today. I remember, times being able to sit down in the bed and talk to the patient, appropriately. If the patient wants you to say, hey, sit down there, or pull up a chair and listen to them. But often you've got that computer thing in front of you, and you've got to type in there. So we have to figure out how to work around that. And doing that, even if you're recording information, especially on a tablet or computer, being an active listener, giving that undivided attention. And it's hard, we're so multitask anymore, and we're listening to a webinar, and you're looking at a text or an email, and or you're at work and somebody just buzzed you. We all get that, and we have to pay attention to it and work really hard at it. And body language, being at that person's level. You have to remember space. And I'm very cognizant of that. And I've had situations where sometimes it's very easy when you're taking care of the patient. Sometimes it's very critically ill to get close to them because they need you to jump in there and do whatever you can for them. And when you're rounding and you have found that. But when you're simply coming in and you don't know the person, you really have to build that space in there. So your body language, not only you have to be the language, but you also have that respect for privacy. And you have to acknowledge them. Are you listening in? Are you giving feedback? Are you non-judgmental? What kind of a thoughtful response? and sometimes people will say things and you reflect back. I want to make sure I understand that, you had this situation with the housekeeper yesterday where she refused to empty your trash can or whatever. You want to make sure that if you pick something up, that you really listen and hear what it is, because you're going to take action from it, or you should. So the other part of rounding is not only listening, being kind and compassionate, being informative, is the value of observation. And that's, building that relationship. If you, are rounding, you're building that relation, but it helps you to be a better observer. It gives you clues to change in the patient's condition, emotional situation. Are they satisfaction care? If they're sitting like this, what's bugging them? Is it you or the care or the doctor, or something happened at home, or they're the patient in the other bed, in the room, we still have some places where we have two patients in a room. And so by observing, maybe they didn't say anything, but you can see what's happening and you can prevent problems, and you can address it right now, than having the person like this, the patient like this, and not refusing to do the treatment because they're upset about something, or somebody was rude to them down in rehab, so they don't want to go down for their physical therapy. I mean, those are things that when you make the rounds, you're asking these questions, you're observing, sometimes they won't tell you. So when somebody's here or like this, how are you going to break down those barriers? And, whiteboard, sometimes putting things up there helps that observation. And sometimes places allow patients to put things on the whiteboard, or a tablet or a clipboard next to them of things they want to ask their nurse, and you can pick that up. And then general thing, looking around the room, as a patient, have they had their bath? Have they had their teeth cleaned? Is their hair combed? How do you package the patient from person to person, from staff to staff? And that's really important. And maybe it's kind of a corny way of saying it, but you want to be able to make sure that the patient looks comfortable, clean, they've got their treatment things to be in order, because that's a perception of how you do business. So, and often when you ask these questions, you make these observations, social emotional problems, that social determinants of health, comes into play. And it helps you identify the issue and the need. And you've got to be a good listener, that we talked about. And when they have social emotional, we know it impinges their recovery. And if they're going to go home, and maybe, if they're an elderly person, there's no one home and they're afraid to go home, so, you've got to ask these questions. And then, if you can't handle, how do you get them to social services? How do you use patient advocates? And in dealing with culture and language issues, that all comes to be in that social determinants of health. Maybe they're worried about the bill and things like that. So that has to be part of what you build in when you're looking at the rounding program, whether you're using Studer or you're creating your own, or whether you're in a clinic setting or a hospital. Those things come into play so much, and we have to be ready to do that. That's why training and scripting becomes so important. Making service recovery work. Okay, so I found a problem. What to do about it? Okay, or I got patients unhappy with their doctor, whatever. So you're going to have to listen. Okay, whether you're the administrator or you're the individual caring for the patient, you're the nurse aide, whatever it is, somebody said, okay, you have to listen, you have to get the details, and you may have to reflect, exhibit kindness, thank them for being willing to share that with them, and find out, can you solve that, or do you need somebody else, and follow up documentation. So you got to listen, and then you got to figure out, can you solve it? And you got to communicate that to them. You can say, hey, I can, you need me to change your meal for lunch, and you're on a regular diet, I can do that for you right now. But let's say, the medication is making you sick, you find that out, then you need to call the physician or the nurse practitioner, whoever it might be. And, or if you found that there's some problems, going home, discharge, or somebody hasn't been kind to you, how are you going to do it? Maybe I contact the unit leader, and document as appropriate. Maybe it's an incident report. Maybe it's, whatever your tools you're using. And, and when you're doing service recovery, lip service versus genuine follow-up. People know whether you're giving them lip service, Don't you know that when you go into a store and somebody says, yeah, yeah, thank you, I'll call you, but somebody says, hey, I really want to know, I've talked to this person, I'm going to get back to you, and they actually do that. So you have to communicate, you have to set time frames. And this is just something simple I try to do every day, even with just simply with emails, even though it's not rounding. It's that follow, sending up expectations. I'll get back to you tomorrow. I can't deal with it today. Or if it's an immediate, obviously a care situation, you have to do it. But if it's a question, I'll get back to you, or I have to call the doctor. It might take an hour or two. I know he's in surgery right now. And that really helps. And then get back to him. Otherwise, it's a negative response. So the patient care team handoff, and this is really critical. And that's, you find this out in rounding, how is that? And how do you pick that up? And when you're doing handoff, and that's really an important thing, is to be careful about that. So when you're rounding, you're going to say, well, Dr. Smith will be in tomorrow or in an hour, and he's new, he's partnering with your current physician or your surgeon, or it's the physician assistant coming in to do follow-up from your surgery yesterday, and introduce that person. And hey, they've been with Dr. Smith for so many years, and excellent, and so forth. So when you're doing the rounding, you're explaining something up, and sometimes often it's that time you do the handoff. They're going to be in for your 15 million. And it is so important to give credibility to your team that you're working, whether it's the doctor or the housekeeper or whoever it is that chance for connection. And, I don't know, when you develop your rounding program, if you want to have some kind of a documentation tool, you want to use checklists, tablets, time frame, but you're going to use it to remember performance and track to see what things you did to make improvement and who and what. So, think about that as how you're doing. And I can give you all kinds of examples. You may have a consultant, you may want to bring your group together to whatever, but these are questions. And what I'm trying to do is introduce areas that you want to cover to have a successful program. So what kind of questions should you ask? Should I ask when I'm doing rounding? There's some, I'm going to give you some other scripting, but there's some things like, and they depending on your position. If I'm a housekeeper making rounded, I'm not going to ask about their medication. I'm going to ask, do you have fresh water? Or, if I'm able to do that, if the person's not on limited intake, or do you, is your bathroom clean? Or if I'm the physician, I'm going to ask about different things. But either way we do it, you want open-ended, simple, and understandable. You don't want to use, how often when physicians round and they ask questions and they put terms in there, and the patients or the family, you look like a deer in headlines, so it's really important. And often when you're doing rounding, or you're in the person, you're going to follow up and say, hey, I was in there when Dr. So-and-so made the rounds. They mentioned X, Y, and Z. Let's talk about that. And sometimes, you're going to ask questions because you're looking at improvement in patient satisfaction scores, such as maybe, quietness at night, or cleanliness of the room, or pain management, or comfort of the nurse. I mean, you may want a particular script in, or make sure that that's covered when you make your rounds, that you're particularly focused on that, and you're looking to see, is the room clean? And regardless, they should be actionable and listed. So, here's some example. Has your room been clean? We're able to make appointment. It's really appropriate to the time, but I think you understand where I'm coming from there. And once again, rounding is about the patient. And so, often you find out you're not going to round on somebody is sleeping and wake them up and say, hey, I've just got to talk to you, or, when you're rounding, you may find out that lab comes in at 6 o'clock or 5 o'clock in the morning and wakes them up, and there's no need to draw labs, and it's part of they're having trouble sleeping. And so those things are, what are you going to do to deal with that? Or you might find out the physician has been abrupt and avoids talking to the family. So these are some of the things you're going to find out. The nurse is not attended to pain, or the daily care not done. Sometimes when you're the administrator, you find out, oh, hey, I haven't had a bath for 4 days. Now, maybe they have, but you find that out. And so how are you going to do it? Water, wastebasket overflowing, and no water or fresh water, medication or treatments missed, and patient social issues that can impact things. I'm worried about my kids getting to school. How caring and empathetic our staff members and patients and families never forget. And these are things that patients see and feel and experience all the time. So how do we incorporate that into our rounding, and how do we deal with that, and how do we script it and make it hardwired and intuitive? And so here's an example of, patient satisfaction scores and in improving your grade. Maybe your unit scores are low for food or noise. You get your HCAPs back, and so what you want to do is I mentioned earlier, bring people together, get them involved, get their ideas. Sometimes it's simply going down and there's been cases where, the food, or, they like the way the food's presented. And you go down and you talk to the dietary, or you watch how they prepare it, and you say, hey, there's always problems up there, always complain about the food being late or cold or whatever. And you start talking about the staff. They say, hey, well, this new servers that we're using to warm, we don't like them as well. They're not keeping it warm. And so those are things sometimes that you find out, that if you start and then you make those changes, then all of a sudden, boy, we really like the food here. Or people have gone from just passing trays. Remember, we did trays in the morning, noon, and night, to, bringing the food up when it's ready, when patients want that, and how that improved the perception of the food, and how dietary has looked at how their presentation of the food is. And noise, closing the door for privacy, at night, if you as you can, and being quiet. Sometimes people put slippers on at night. Just a variety of things that you as a team can come together and say, well, what can we do? Are we talking too loud at night? Maybe we need to go to a different area for breaks. Maybe the breaks door's not being shut. A variety of things, but you don't know that. And then you initiate those changes, and then you can begin to evaluate. But it can't be just you, one person doing it. It has to be the team. So once again, it needs to focus around, if you're dealing particularly with inpatient HCAPs, or if you're dealing with clinic surveys or swing bed, whatever it is, looking at these areas and looking at what you're focusing on, and looking at your scores, and then talking with your team. So some other examples. I wish we were, like I said, sitting around and having a conversation. So how often, you're saying, how often do you need help getting to the bathroom, or need the bedpan, your call button, and that's something that's actually in there. And so if you're rounding, this is something that's been low, is talking to the person about it. Did they have to, when they did the rounding, did the nurse come in every hour? Sometimes you have people on training, you've had the Foley cath removed, and keeping them informed on that, making sure that they can get to the bathroom, teaching them about, maybe you're recording the urine, and the amount of urine, and explaining to them about, needing the help so you can measure the urine, and all those things help in explaining, other than just in saying, oh, you dumped the urine again in the bathroom, and we needed to, so then pretty soon the patient has a negative perception of that particular part of helpfulness and comfort of the nurse. So during this hospital, say, how often was your pain well controlled? Here's an example. A young man was in a motorcycle accident and didn't, just kept saying, no, I don't have any pain, but yet was wincing, and you knew he had broken bones, and sometimes, and the mom comes in, and sometimes talking with the mom, you can find out more about the patient, and there's different ways of asking the question, and saying, does does your leg hurt? Where did you hit, when you had the accident? Do you remember? And does that impact, is the pain improved? Just talking with family members, or zeroing in on how pain is going to, you just sometimes just don't come and say, how well is your pain control? I know that's the question in there, but your question making rounds, how do you build that perception that you really want to manage and control the pain, and thinking about each patient, and how you're going to get at their level, and help them to understand. Maybe so it's a language barrier. If you're dealing with a Hispanic patient, do you have somebody that's able to, relate to that, or, using the pain, the, smiley face, pain thing. So And how often was your area quiet at night? I mean, there's different ways of saying things than just actually questions in the survey. And that's part of your team working through that and how we can build on that. So rounding is, as I said, it's a tool to improve your scores. You can create your own program. You can, and they're generally you start in the inpatient setting, maybe in one particular area. You can start in your clinic, or you can do administrative rounds, whatever it is you want to do that you really want to focus on to prove your scores with perception of the hospital. Maybe that's an administrative thing. If it's care and comfort by the nurse, it's a nursing thing. If it's your physician, maybe it's something you need to deal with the if you got a hospitalist program, and the medical staff, it's concerns about them and how do you improve those scores, and getting everybody together. You can create your own program. You can follow Studer's template or others, and that's sometimes a guide. There's a lot of articles and materials out with Studer. You can go down and download a lot of this stuff, but it really has to be genuine and at your level. And then when you do, look at your culture. You need to make the decision. Who's involved in it? You need to plan. Who do you have involved? When are you going to start? How are you going to do it? Train. Is everybody involved in that on your unit? Or if it's house-wide, it can't be just start tomorrow. You have to implement. And what are you going to measure? So that really inflects your scores. That's why you have to look at your survey results. And if you're, whether it's a tablet program with swing beds, or whether it's a soon to be home health or inpatient age caps, whatever it is, you can do rounding it in home health. You do the visit, what you're going to do during the visit, and then you can do phone calls. I mean, there's just a variety of ways that you can do it, but it's a way of a periodic evaluation and checking on the patient, regardless, whatever. But once again, measuring it and then evaluate. And what you've been doing, has it worked? Did it improve your scores? Are you getting better? Are people outcomes better? Are people responding to treatments better? What were your expectations you set for your program up front? And if they're not meeting it, change. What do you need to do different? How do you evaluate it? So, making that decision, getting everybody, planning it, getting everybody on board, training. Do you have the right culture? Implementing it. There's going to be, prickly situations, or somebody forgot to do that, or not very good at it. How do you measure it and evaluate it and make change? And then, do you get that A? Do you go from an 80, a B minus, to an A plus? Obviously, with inpatient scores, you can look at how you compare to others, with hospital compare, with survey solutions, we're building outpatient benchmarking and so programs. And so how do you compare with others? Like I said, it doesn't fix all your problems, but it's a tool that you can use. And we can talk about specific situations and ask questions. I can share additional information that I found over the years that I've used, but it's still always about the patient, and let's do our best. And it's a patient experience. And if rounding is a way of building that communication, breaking down barriers, creating a better experience, and it really doesn't cost any money. You don't have to go out and buy fancy new equipment. There may be some costs and some education and training, but it's going to be the rewards in the end, because boy, I was at hospital, I'm going to say Franklin Hospital, or one of our hospitals in our system. I was at Horizon Health, and they just done such an awesome job. The nurse or the care team leader or the administrator came and met with me, and we did rounds every day, or they really seemed to care about me. And I wasn't just put in a room and somebody came periodically, checked my IV and left. We don't want that. It's about the patient experience, and it always ends with a better outcome. So, you're part of our survey solutions. We want to bring educational programs and ideas and ways of improvement to you. And we plan to offer these educational programs on an ongoing basis moving forward. We've done some in the past, but we're going to try to be very intentional about how we're doing that. So if you have any questions, I guess I didn't give my contact information, but most all of you know it's Pat Scow, PSCHOU at ican.org, or you can contact Survey Solutions staff that you work with every day. You know, Holly Lendy, you probably all know Holly, you probably all know Jake, different people within ADCO, but give us a call. We'll do what we can to help you. And if you want some help getting started, we're happy to help and share information. But hopefully that this is, I've met some of the ideas that you've had about rounding, and you're thinking about your experiences, and take it and see what you might be able to do within your organization. So thank you and have a great rest of the week.